Good evening, everyone. Welcome to our telephone town hall meeting with the Texas Medical Association. We are dialing out to thousands of your fellow members right now. Please remain with us. We will begin here shortly. We will be discussing the issues in medicine that will have an impact on the legislative session that will begin in the State House in January of 2019 here. And we're going to have a very lively forum this evening with several speakers, as well as asking you and our listening audience to answer several live polling questions. We will also be having a Q&A period as well. So if you have questions regarding the top issues in medicine that might have an impact on the state legislative session or be impacted by the state legislative session when it begins in January. And so with that, I'm going to hand it off to our physician host for the evening, Dr. George Santos, President of the Harris County Medical Society. Dr. Santos, thank you so much for joining us this evening.
Thank you, Jason. Good evening, everyone. Welcome to the Texas Medical Association Telephone Town Hall meeting on legislative priorities for medicine. This is in preparation for the 2019 session of the Texas Legislature, which convenes in January. Tonight's session is the third in a series of 5 area teletown halls that TMA is hosting. At this time, it's my pleasure to welcome the TMA President, Dr. Doug Curran, to our Harris County Medical Society offices and boardroom. He will be joining the call shortly. Dr. Curran is a family physician with UT Health East Texas and Lakeland Medical Associates in Athens, Texas. He graduated from the University of Arkansas for Medical Sciences and completed his residency at Southwestern Medical School Family Medicine Residency Program at John Peter Smith Hospital. Dr. Curran has spent over 42 years advocating for patients and physicians of Texas, medical liability reform, patients' rights, improving CHIP and Medicaid, scope of practice fights. He's been involved in all of it, and he's worked all of those problems. The self-titled country doctor is proud to have cared for generations of the same families in his hometown of Athens. So welcome to Houston, Dr. Curran.
Thank you, Dr. Santos. It's good to be here. It's always fun to come to Harris County and visit with doctors. I spent the day with a number of different groups, and really exciting to see what's going on in Harris County. I just want to remind everybody that the Texas Medical Association is the largest medical society in the nation, and we certainly think that, by far the best medical society in the nation. We have over 51,000 members, approaching near 52,000 now. We have all medical specialties. 112 component medical society, county medical societies make up our association. I think it's important to remember, too, that Texas physicians are economic drivers in this state, and we're proud of that. I think we're able to employ people, we're able to empower people, we keep them healthy so they can keep working as well. But just as an economic driver, there are 52,550 physicians that practice actively taking care of patients in Texas. The total number of jobs created by those 52,000 plus physicians is 670,000. The average physician creates 13.1 jobs. They help to make that happen in the economic arena of our state. We generate physicians $118 billion in economic benefit for this state, and that compares to $43.5 billion from the legal services that are out there, and higher education contributes $10.98 billion to the mix. It's just we're a significant economic driver. We're going to have a lot of things happening in this next legislative session, and I'm looking forward to conversations about that as we move forward.
Excellent, thank you. Next up is Dan Finch. Dan is TMA's Director of Legislative Affairs and has roots deep here in Houston. He will act as our traffic cop, keeping things moving through tonight's TMA Teletown Hall meeting on legislative affairs. Dan?
Dr. Santos, thank you, and thanks to the Harris County Medical Society for hosting us tonight. I get to play traffic cop tonight, or actually conductor on the train, and my job is to help this train run on time and cover as much ground as we can. First, a few ground rules. We're going to cover the discussion with Dr. Curran in a number of different areas. budget issues, which including Medicaid, maternal health, graduate medical education, insurance issues, which I know are always a deep concern, public health issues, including vaccines and other preventive care issues, and then finally practice issues, including scope of practice, corporate practice, the opioid crisis, and then anything else that's on your mind. We will have several polling questions, and we'll get to them. And then last but not least, you do get an hour of CME credit for this, and for this program, it is an hour of ethics. Now, I'm obligated by our attorneys to read the following statements, which I'll do quickly. Policies and standards of the TMA and Accreditation Council for CME and the American Medical Association require that speakers and planners for CME education activities disclose any relevant financial relationships they may have with any entity producing, marketing, reselling, or distributing healthcare goods or services consumed by or used on patients whose products and devices and services may be discussed in the content of CME activity. TMA designates this activity for a maximum of 1 AMA PRA Category 1 credit. This course has been designated for 1 credit of education in medical ethics and professional responsibility. TMA is accredited by the American Accreditation Council for CME to provide continuing medical education for physicians. Physicians who remain on this call for at least 53 minutes will automatically receive CME credit. We will ask a survey poll question near the end for your CME credit, and the answer in advance will be get involved, attend first Tuesdays, subscribe to the legislative hotline, and answer action alerts to talk with your legislators. So this is an election year. Let's move on. It is an election year. We're not quite finished with the elections for 2018, and we're delighted to have Dr. Brad Patt from Houston, who's a member of the TexPAC, the TMA Political Action Committee Board of Directors, with us for a little bit of a political landscape.
Thank you, Dan. Thank you, Dr. Curran and Dr. Santos. TexPAC is TMA's Political Action Committee. We've been aggressively involved in primary and general elections this year. We're supporting our friends in the Texas legislature. We're engaging old friends and making new friends. To be clear, TexPAC success, medicine success, is driven by local physicians. We need their involvement. Candidate interviews, local physician involvement in campaigns, educating candidates on medical issues. We're stronger with your involvement and your membership. The last day to register to vote is October 9th, and early voting will begin October 22nd and end November 2nd. Election day is November 6th. No matter what you do, please try to get out and vote. While we don't know the final composition of the Texas House and Texas Senate until after the November 6th general elections, here's what we do know. A special election for a state Senate seat that runs from southwest San Antonio west to Del Rio was won by the Republican candidate in a traditional Democratic district. If nothing changes, that gives Republicans a solid 2/3 majority in the Senate, 21 of 31 seats approximately. Expectation is that there could be anywhere from 5 to 10 House seats that flip from Republican to Democrat. But that means the Republicans would still have a large majority. For those of you who have made contributions to TexPAC in the past, thank you. We need continued and new support at all levels. For those who are involved with local candidates, we thank you as well. We need more of you.
Dr. Patt, thank you very much. We're also honored to be joined by Jason Turk, who's chair of the TMA Council on Legislation, and Dr. Turk is a pediatrician from Fort Worth, and once the table is set through the elections, then the legislature starts in January and runs for 140 days. Dr. Turk, can you give us a flavor of what we expect?
Yes, sir. Well, we're going to be seeing about 7,000 bills and resolutions introduced in the next legislative session. About one of these are going to be dealing in some way, large or small, with health care. And like it or not, the legislature's effect on our practices and our patients is huge. If you're not at the table, then you are surely on the menu. I assure you TMA will be present and heard from to defend what needs to be defended and to advance the cause of our patients and the physicians who take care of them. While the Senate and its presiding officer, Lieutenant Governor Dan Patrick, look to return with a supermajority in 2019, the same cannot be said about the House of Representatives. First, the House must elect a new speaker, and while that has been the subject of great discussion around the state, it also means that we will have new committee chairs, new committee members, and new committee staff to hire. So while we expect the Senate to quickly begin its work, It may be some time before the House infrastructure is truly in place. That's going to act as a speed bump for at least the first month of session. At the end of the day, the legislature has only one must-pass bill, and that's the state's budget. Typically, that process takes the entire session to iron out, and other bills are often held hostage by one chamber to pass its version of the budget. Maybe this is the year that they will pass only one bill, but I certainly wouldn't count on that. Last thing, I'd like to thank the other 17 members representing both primary care and specialty care on the TMA Council on Legislation and the incredible lobby staff of the TMA. This really is a hard-working group, and they spend countless hours looking at and developing the best approaches to our issues. If you have questions about a particular issue, please reach out to one of the members of the council. Thank you.
Thank you, Dr. Turk. Appreciate you joining us tonight. Dr. Doug Curran, we're back again, and this is your fabulous tour of Texas these days.
That's right, Dan. We've done this. This is our third go. Maybe we'll get it right.
Maybe we'll get good at it.
That's right. We never know.
Let's talk about some of the issues that medicine faces in the coming session, and very often they're the same issues that we faced in previous sessions, and so much of what we deal with is driven by the budget and money. Healthcare is a huge business in the state of Texas. For a biennial budget of around $210 billion from all sources, a third of that is spent on health care and a good portion of that on Medicaid. Talk about Medicaid, some of the issues we face and some of the challenges.
Sure. Well, as you said, Dan, Medicaid is the largest single state budget item. And, of course, a little play on words there because some of those are federal dollars, as you know, but still it's an enormous item in our budget. And it's a significant issue as we move forward. It's always an issue that's out front. But the reality is that as physicians, we've not seen any change in payment for physicians for taking care of Medicaid for over 2 decades. And that's just unacceptable. We can't continue to do that. And so I think this year we have to ask for an appropriate payment for taking care of the patients that receive Medicaid services. And I think it's also of concern because it's telling insurance companies that we'll take that lower amount, and so they're trying to negotiate lower amounts as close to Medicaid as they can get. We have to put a stop to that. I had the privilege of visiting with a group of orthopedic surgeons, and they're being pressured by a lot of insurance plans to just take a lower amount of money because Medicaid, they're taking Medicaid. They're doing the right thing, and as a result of that, everybody's pressuring us to take less, and you can't pay your bills if you take less. We're small business people. We already talked about the economic driver. We've got to be sure our legislators understand that, and Medicaid has to be something we deal with during this session. It has to circle around payment and access.
And we've spent a fair amount of time focusing on maternal health issues this year, and initial numbers look like that the maternal death rate in Texas rivaled that of a third world country. But on closer examination, what seemed terrible now is merely bad. Talk about some of the issues that we will face in maternal health moving forward and how we deal with this.
Well, there's no doubt. You got to remember that a little over half of the babies delivered in Texas now are Medicaid deliveries. So again, payment, appropriate management of the Medicaid patient who is pregnant has got to happen, and a lot of the deaths are in that category because they're poor and they also have less access to care.
But when a woman gives birth to a baby and the birth is covered by Medicaid, how long is they're currently covered?
They're covered for about 60 days, and that's got to be a year. That's what we're going to ask for. And I think that's just appropriate. If we want to really make a difference, we've got to take care of the patient for the period of time that they need our care. We have to see that because we see a lot of issues with moms during that first year, and we got to be able to take care of them appropriately. And of course, the Medicaid spins around all of that, so we're going to have to work with that. But the maternal health issues, we had a Congress at TMA, and we have come out with some ideas and some plans, some issues which we think will really help in improving quality of care for women so that we won't have issues of maternal loss. And our goal is to be sure that maternal loss is at 0 by 2030. Now, it's just a The 2030 sounds like a long ways off. It's not, but we can get this done. And I think reflective of the information that came out from Texas is an indicator for the inadequate attention that's being given to health care. So we got to focus on that so that we get good information. Can't make good decisions if we don't have good information. And the stuff that came from the maternal issues are just reflective of the data we're getting.
I know that very shortly coming up, you're spearheading a meeting with the managed care organizations in Austin. Tell me some of the things, items that will be on that discussion.
Well, first and foremost, a little bit of their integrity will be on in question. As I hope some of you had the privilege of reviewing information that came from the Dallas Morning News articles about the way patients are cared for in managed care environment. It was pretty depressing, and we have to talk about those. We've seen Representative Davis's committee, representative here in the Houston area, her ethics committee reviewed all that, and they came down pretty hard, and we're hoping that they'll take some real action in that area. But we're also going to talk about credentialing. Even if you want to serve this group of people, trying to get a physician credentialed can take almost a year. In our small county, we have one pediatrician. She just joined our group in August, and we started trying to get her credentialed right after the first of this year. And she's still not credentialed completely. And that is just criminal. They ought to be ashamed of themselves for not getting that done. I think we can find out what quality she is. You and I could do that, Dan, this afternoon on the phone, with just 2 or 3 phone calls. So this is harassment. It's inappropriate. It's ridiculous. And we're going to shine a bright light on that. We're going to start shining that light next Friday.
Well, thanks for drafting me for yet another job.
Another job. That's right.
One other issue that the budget impacts on greatly is graduate medical education. Right. We have fought for years, and successfully so, to expand funding for GME, and last session even enacted formally by statute a ratio of 1.1 first-year residency slot for every graduating medical student. And now we have 3 more institutions announcing plans to build medical schools: Sam Houston State in Huntsville, University of Houston here in Houston, and TCU in Fort Worth.
Absolutely. Graduate medical education has to be addressed. If we don't address that with additional funds, and it's like so many things, Dan, we have to remind the legislature what they decided to do, then that they've really got to stick with what they decided to do. And that 1 to 1.1 ratio, you hear that from a lot of the legislators. They seem to get that. They remember how important that is, because if you don't, you kind of stay where you train. And I'm living proof of that. I went to medical school at the University of Arkansas and did my residency program at John Peter Smith Southwestern Medical School's Family Medicine Residency Program in Fort Worth, and I practiced within 120 miles of Fort Worth. So it really works. It's reality. 80% of them will stay within that 200-mile radius.
And that is as true today as it was a generation ago.
Absolutely.
And it's not that we don't need new physicians. I mean, we have a fast-growing population. The number of physicians that are licensed every year by the medical board exceeds 5,000. 15 years ago, it barely exceeded 2,000. So we are growing by leaps and bounds, and yet we still have trouble maintaining and gaining on the population, the physician to 100,000 population ratios.
Yeah, absolutely. We've got to shine a light on developing and building residency programs. Dan, our state last year grew by 400,000. We're on track to gain by 500,000 this year. And if you look at, even though we're increasing in the number of physicians, if you look at primary care physicians, primary care physicians to populace, we ranked 47th nationally. So even though we're growing in docs, even though we got more, we still don't have near enough. And we're not going to have enough unless, even though we build medical schools all day long, if we don't have residency programs, we're not going to have doctors. They'll go away and do their training, and they'll stay where they go.
Jason, with TeleTown Hall, let's ask the first polling question.
Certainly, Dan. To those of you in our listening audience, this is our first of our live polling questions. You will be able to respond by pressing numbers on your telephone keypad. Our first question for this evening, per our discussion, is which do you believe Texas must prioritize to build the physician workforce? Press 1 on your telephone keypad if you believe it's more medical school capacity. Press 2 on your telephone keypad if you believe it's more GME capacity. Press 3 if you believe it is both of those. Press 4 if you believe it is neither of the first two options. And press 5 if you are unsure or undecided. We're going to be having several other polling questions, so please remain with us for tonight's event. And back to you, Dan.
Thank you, Jason. And as we watch the numbers come in, it seems almost equally split between more medical school capacity and more GME capacity. I will take that to mean, Dr. Kern, that we need both.
We need both, but we need more GME.
Okay.
We got to have more GME.
Without a doubt. Let's move on to issues related to insurance because they're always important in the legislature, and every year we face issues that would and efforts that would prevent physicians who are out of network from balanced billing. We have growing issues with this with the burdens placed on physicians and physician practices by pre-authorization, gone wild in many respects, payment issues, the lack of payment for the Blue Cross saying that we're going to retrospectively deny emergency payment for emergency services if we deem it not to be an emergency. I mean, these are very chilling and very difficult issues.
Yeah. Our insurance world becomes more and more complicated, and I think physicians are more and more managed by insurance companies. They want to direct and guide exactly what we do and how we do it, where we do it, and the complications, the complexity rather of our system avails that opportunity because there's no direct correlation to billing and how much is paid and who pays what and what goes on. So the payment system is very complicated. The lack of transparency is so confusing. And the limited networks kind of force patients to go somewhere else because they can't get in. It's so narrow, the networks are. I mean, in our area, it's really hard to find somebody who takes Blue Cross HMO that's a specialist. It's just few and far between. And that's the only insurance plan that's in our area that you can buy just off the street unless you're working for an employer or something of that sort.
The administrative burden placed on you has grown exponentially in the last number of years. And I wonder how many of the 13.1 jobs that you are responsible for as a physician are related to claims filing, other administrative positions, and not necessarily healthcare.
Oh, a significant number. I mean, there's no doubt about that. You just have to have so many people to get the information over to the other people, and the information usually is worthless. It has nothing to do with getting it done other than getting the authorization for the patient. But the administrative burden, as I've traveled the state, that's what I hear most from physicians. They just are sick and tired of that. It has nothing to do with taking care of the patient. It's just harassment mostly. And I think during this session we have to look at some of that. We have to figure out some of this stuff that's not necessary. I don't know about other physicians out there, but I've had to prior approve albuterol. And that just seems ridiculous to me. I mean, it's a generic drug that's out there. It's been there a long time, and we've just got to take a firm stand on stopping some of this unnecessary burden. And we have to refine issues with the electronic record. We got to do better with that. We got to get better information that we can use, and we need to be able to share it better. So we have to work on some of the issues of the electronic record. But ER policies are strategic, and the threat that Blue Cross pitched out there to not pay it's just alarming, and I hope no one stays away from the emergency room who's ill. If you're ill and you need to go to the emergency room. I think it is important to be aware of the closest emergency room that fits into your agenda, your pay schedule, or whatever. But if you need to go to the emergency room, for God's sakes, go to the emergency room. And Dan, the other problem we got too is telemedicine is out there, and we passed great laws during the last session. As you know, you worked very hard on those things, and the they're not paying for that. I'm getting paid by Medicare when I bill because we're in an underserved area, so we can bill Medicare, and they're paying us for telemedicine, but none of the plans are. I'm not getting paid by any of them, and we're trying to get payment for doing that.
In 2017, on the telemedicine bill, it was based on the premise that the same standard of care that applies for in-person care applies to care that you provide via telemedicine. And we basically took away the restrictions on site of service so that, you know, quite frankly, right now my living room can be a site of service. But so long as you exercise your judgment about providing care that meets the same standard of care, it is a viable way, it is a viable means of a tool in your toolbox to care for patients. It's not the service itself, it's the means of providing the service. And one of the things that we required is that the plans must post their payment practices and descriptions of how they will handle claims on their websites. And we know from verification from outside sources and in our own review that less than half are actually doing that. The third thing is payment. And as you've said before, a covered service provided to an enrolled individual by a contracted physician should be paid for. We should not be driving people away from their own doctors in terms of seeking care.
Yeah, that's correct, because of course they've tried to use telemedicine companies and leave out the personal physician, and as a result, you know, I think it fragments care, and it's not near as good. And if you can provide telemedicine directly to your personal patients, then you keep them out of the emergency room. You really save a lot of money for the system, and why we can't get that across continues to be a struggle.
Like so many issues that we deal with, this is not an issue that is solved in one session in the legislature. All these issues are complex and the solutions evolve. Jason, would you ask the second polling question, please?
Certainly, Dan. Per the conversation of telemedicine, we'd like to know whether or not you in the listening audience currently or will use telemedicine in your practice to care for patients. Please press 1 on your telephone keypad if you do use telemedicine. Press 2 on your telephone keypad if you do not. Press 3 if you plan to. Press 4 if you're unplanned to. And press 5 if you're unsure about using this or it's not necessarily applicable to your practice. We've had great participation on the polls, and we thank you for your time and joining us this evening. Again, if you have a question in our discussion tonight, please press 0 on your telephone keypad. Back to you, Dan.
Great. Thank you, Jason. I can tell you as we watch the results tabulate, 21% of you say you do participate in telemedicine arrangements, and another 14% say that you plan to, and I think that is exactly what we're going to see. You know, my goal, and I've told you this, Dr. Kern, is that when I retire, I intend to Skype all my doctors and have all my drugs droned in from my backyard.
Well, Dan, I can remember our family doctor coming and seeing my dad when he was ill one time, making a house call. So I think it's almost the new house call way. You know, you can Skype your patient. You should be able to do that, and you should be able to get payment for that. But you also should just be able to talk with them and get payment for it, because I know my patients, and then I can arrange to see them in a few days afterwards. And I've been accused of double dipping if I do that by insurance executives, but I don't care. It still saves them a ton of money if I keep them out of the emergency.
Well, and it is a solution to it is one of many solutions to the lack of after-hours care. And certainly, but I also think, and I know that Medicare is revising its payment policies and procedures with regard to telemedicine, and I think more than anything else, Medicare is the 800-pound gorilla in the insurance world, and what they do, the commercial companies and follow, for better or worse.
Sure, and in reference to that, I worry a little bit about what Medicare is trying to do with the payment schedule for physicians, that insurance companies may try to drop into that, and which would affect especially primary care physicians. I think our request for hearings on those items of bundling payment for level 2 through level 5 visits as one payment, we asked for hearing on that, and hopefully we'll get that hearing with Congress. We've asked for that, as you know. We sent it in, and trying to get that to happen. If that will really help us a lot in resolving some of these issues of payment and fair payment.
I agree, and I appreciate you bringing that up because I don't think I've ever seen a stronger letter demanding a hearing on issues come from the association to members of Congress from Texas in terms of basically demanding that this be done because of the incredibly bad effects this is going to have. If we have several folks who are in line to call and who are holding on the line to ask a question, and I wonder if we can have Dr. Nora Klein. Dr. Klein?
Yeah. Can you hear me?
We certainly can. Thanks for joining us. Please ask your question.
Yes, thank you. My question has to do with the expansion of insurance. Texas has the worst percentage of insured people, 25% not insured. We have the opportunity to take on what was offered by the federal government to expand Medicaid, and I think we need to very seriously think about doing that. They would pay for, as I recall, 90%. We have this horrendous maternal mortality statistic, and I want to say I looked at this very carefully over the years, and I noticed that in the last decade, our maternal mortality doubled, and that's not because the population changed that much, I don't think. It's because so many maternal clinics were closed down, and we just can't get away from that fact. So that's the next thing that really needs to be done, rev up the clinic system for maternal care. And that should include care beyond.
Thank you, Dr. Klein.
Yeah, Dr. Klein, that you are absolutely correct on all points. I should tell you that the TMA House recommended that we take the federal dollars, that we draw down the federal money, and that we offer that to our working poor. And we voted to do that by over 75% of the House of Delegates, and we did that back a number of years ago. And we have continued to try to move forward and move that in that direction. We've just been unable to move the legislature because it's such a politically charged issue. And we're going to continue to work in this session to pull down every federal dollar possible. And I agree with you 100%. The issues of care, and especially in maternal care, have to do with access. And access is not going to happen unless we have adequate payment. And we're seeing small rural community hospitals go down right and left. In my community, we're about 125 miles from Dallas, and there is no place, there's no hospital between my hospital and the inner city of Dallas where there's not a hospital on the outside edge of Dallas on our side. So there's nobody delivering babies from Athens to Dallas. So these people are having to go. They're either coming to us or they're going to Dallas to get care. And it's just inadequate, and if these people have limited resources anyway, they need to be able to get care close to home. And trying to make all that happen has been an unbelievable challenge in an arena where there's just not enough funds to make it happen. And you know, those federal dollars are your tax money and my tax money, and we have to be clear, I think, with our legislators that our expectation is to draw down those federal dollars for our people. And we're going to talk about that this year. We'll do our best to make that happen. But it is a politically charged issue, but we're going to try to diffuse a lot of that and be sure we draw down those dollars. We're working on it.
Very good. Thank you. Dr. Diane Collins. Diana Collins has a question about insurance coverage for Dr. Curran. Dr. Collins?
Yes, I'm a child, adolescent, and adult psychiatrist out in Sugar Land. And what I've experienced this year, and I just was wondering if anybody else has experienced this, but I have two insurance companies I deal with, and I've had one insurance company that decreased my reimbursement payments on patients by 3%. And the reason they told me this is because they did not get these surveys back from my patients, which were forms that they wanted the patients to complete that many of my patients feel uncomfortable filling out. And they include questions such as, you know, do you smoke? How much do you drink? And they have other questions included on there. But, you know, my patients feel uncomfortable filling those out. But that's what the insurance company told me. Oh, that's why we, decreased your payments, because we aren't getting these surveys. from
you're not hitting their patient satisfaction score.
Yeah.
I'm sure that's happening, but I'm telling you, they're going to use any excuse they can to decrease your payment rate. It's not if it's not the forms, it'll be something else. I think the world we currently live in is really driven by they're going to balance their budgets on the back of the physicians. If you look at everything that's going on, the hospitals, other areas have continued to receive some cost of living changes, but physicians have been flat for a long time or going down. And that has to stop. And it's going to stop whenever the state changes some things. Whenever they begin to pay better for Medicaid, then the focus will get better for all of the other insurance issues because other opportunities are then available. So we have to get the Medicaid rates up to a reasonable level, and then we'll see everything else begin to climb some. And I consider what you're explaining to us is as an issue with administrative burden. And we have to deal with all that garbage that's out there that has nothing to do with our caring for patients and practicing medicine. That's going to be our effort as we move forward. Do you happen to know which payer it was that was doing that? You said there were two. Which one of those payers was doing that to you?
Oh, United Healthcare.
Okay. Well, we can reach out to them too. TMA can. We will take a run at them to see what's going on for you.
Dr. Collins, Dr.
Yeah,
Collins,
that's the one that most problems with.
If you will stay on stay on till the end of the program, please leave us a voicemail with your email address and let us put someone in the payment advocacy department in touch with you later.
Oh, thank you so much.
Very welcome. Thank you for joining us. Let's, moving from this, it's almost an issue whiplash to move from insurance issues to public health, but the TMA is physicians caring for Texans, and public health is a huge interest historically for physicians and for TMA, and it remains so even in challenging times. Vaccine issue. I mean, vaccines are the biggest bang for the buck in medicine because of the relatively small amounts of money invested in them, which leads to great payoffs in the prevention of disease. And yet, every year we fight to maintain good vaccination rates.
Right. Oh yeah, Dan, we always have to fight that. We have this small group of people, and realize it's a very small group of people that are out there that are very vocal about the bad issues with vaccines, none of which is true. They use distorted, inadequate, inappropriate, wrong information, and for some reason or another, some of our legislators feel like that there is a huge group of people out there that's going to come after them. And the truth is that's not the case. TMA did a study, and that study came through the Texas Public Health Coalition. And in that study, we found out that typical Republican voters, 86% of them support the current laws that have to do with vaccines, and they support students before they go to school have their vaccinations. So this idea that there's somebody out there that's going to eat a legislator alive if he votes for vaccines is nuts. It's just not true. That's just all there is to it. And those issues with clean water and sanitation and vaccines are what's made more difference in our caring for patients than almost anything. So we got to stand so strong for vaccines. And I think this kind of data coming to us gives us great information so that we can have the influence we need to have at the Capitol so we can keep vaccines strong in our state. And the expectation is to even strengthen them. We're going to bring back our law to get information out about where it's safe for what the vaccination numbers are on different campuses so that we'll know which school immunosuppressed kids ought to be at. We want those safe things to be happening for our students.
And to clarify, last year we had a bill, and we will again this year, and that is for schools to publish by campus the vaccination rates, not to identify individuals.
No.
But so that people can make informed decisions and see. And I know that we'll be back with that. One of the other issues that we deal with in the last number of years and will again next year, has to do with advanced directives and end-of-life care.
Sure.
An extraordinarily sensitive part of practice and fraught with with the emotions of family members, and yet the ability to adhere to a patient's wishes and do the right thing seems to be always under attack in these situations.
Well, contrary to popular opinion, issues of end of life are just they're so complicated, and they spin around usually the families. A lot of times I've already had my conversation with the patient. I kind of know what they want, and trying to get that to happen, especially with the law change and the confusion and that kind of spins around that. And I've discovered that almost every hospital has its own policy that it's going to use in the issues with end of life. It gets really frustrating in trying to get that organized. So we're going to have to do a better job, and we're going to have to revisit some of these issues and try to get clarity about end of life issues so patients can make good decisions, and so we as physicians can make good decisions. We're spending a lot of money in the last few weeks to months of life that may be really futile, and it's something a lot of times the patients don't want, but family will scoop in from a distant land, and they haven't seen grandmother in 5 years, and she went from 70 to 75, and a lot of bad things can happen to you during that time, and they just don't understand what all's going on. But there's no clear definition of how the patient wants to be managed. So we've got to get better information, better communication with our people about how things need to happen, and we have to have some clarity in the advanced directive arena.
Right. Let's move on to the sort of the final catch-all all issue for tonight, and practice-related issues, which is a broad category of issues related to corporate practice and in times gone by, physicians were in private practice or that was primarily it, and yet right now there are a multitude of arrangements for physicians to practice their profession privately, solo practice, large group, small group, multi-specialty group. You have it, and of course a growing mechanism for, face it, for compensation of professional services is employment by a nonprofit healthcare corporation or other entity. And talk about some of the issues that we face and will face in the legislature in this regard.
Now, the corporate practice of medicine it's happening in Texas right now, and it's illegal. And I think we do see a number of physicians that are being told out of practice. I was in Fort Worth a week ago when we did our TeleTown hall there, spoke with a emergency room physician who asked me if any other physicians were having this problem. He was being told ahead of time what he should order, and I'm aware that some of them, if a patient comes in the emergency room who's maybe 50 years old and has a bruise on his chest, he has chest pain, so he gets a complete workup for cardiac issues, and I think that's happening in a lot of levels.
Sure.
I hear from other family physicians who are employed that the expectation is if they see a number of back pains that they should be ordering X number of MRIs. And I think we have to address those issues. That cannot be. People are practicing medicines without a license, and we can't have that. They're trying to influence physician decision making, and we have to resist that. And we have mechanisms for that in place. The medical board can step in and do some things, but we got to empower that during the next session.
Sure, and I think that's one of the efforts that we made last year. And I will go back to 2011 when we passed a law that generally prohibited interference in independent medical judgment in physicians employed by nonprofit healthcare corporations, generally owned and run by hospital entities, and yet the issues persist. And last year we brought a bill to the legislature that would establish a process and procedure at the Texas Medical Board to adjudicate these kinds of complaints. And we're not successful, but we will be back because it's important that The medical board is the entity that certifies whether a nonprofit healthcare corporation can proceed with a physician board of directors to employ physicians and provide services. And since the medical board certifies them, then the medical board is obligated to have a process to adjudicate these kinds of issues and allegations.
Exactly, and I think if they begin doing that, it's going to pull things back a little bit, and we'll see some reasonable behaviors return to the 501As. But currently, they're pretty much doing whatever they want to do. So we just need to be sure that physicians are able to practice medicine the way they think is the best way to practice medicine. I think it's the entrance into the exam room, Dan. You know, we fight that all the time. The exam room is sacred, and it should be left to the physician and the patient.
And it's already pretty crowded.
And it's already crowded. We got plenty of people in there now. And trying to get everybody out so it just is the two of us is really strategic, and we're going to work real hard during this session to see if we can make that happen.
Yeah, sort of along the lines of the medical board, of course, their sunset bill, the reauthorization of the Medical Practices Act and the agency is back on for this session because, you know, let's face it, it was the hostage that was shot last year in order to force a special session. We don't anticipate that happening again this session, but we also do anticipate that there will be improvements to the medical board's processes, to the more transparency, and quite frankly, I think what we will see this year, and we've had these discussions with the board, is an expedited licensure process that will allow an out-of-state physician in good standing with no disciplinary history to really seek a very quick approval and granting of a Texas license. Again, part of this whole need to grow the physician population in our state to take care of a growing number of Texans.
Well, I don't think there's any doubt that this is going to move forward, but we can't take anything for granted, Dan. And I always worry about whenever the Medical Practice Act is open that people will try to move in and change some of the language. You know, you worry about scope when it's open and the definition of diagnosis. Yep. You worry about all those things. Now, fortunately, we have some real strategic players on the Sunset Committee that have been really helpful with us. And it goes to show what we were talking about with TexPAC and other things.
And ironically, one is your
one is my senator. As you know, he is the vice chair of the Sunset group, and he and I had a conversation at the Capitol a few days ago, and we were visiting about that. And I said, Senator, I know that our bill is up, and I know you guys have moved it out. And I said, I really don't want to happen what happened last time. What do you think about carrying this bill for us? And let's get it out there first, and let's get it done, because we get some early victories, maybe we can get some bigger victories later. And I said, I know you have some relationship with the Lieutenant Governor, and I just appreciate you maybe helping make that happen. And he said, you know, Doc, I think I can make that happen. So that's what happens when you build relationships with legislators. They really want you in their tent, and they want to help you get things done because they know we're trying to do the right thing for all Texans.
Absolutely. And move on to an issue that is first and foremost both in the public press and for physicians in our association. That is dealing with opioids. And you know, the legislature last year took some really significant steps forward to enact policy that they believe going forward was going to be helpful.
Right.
And yet, here we are 2 years later, and 2 years farther down the road, quite frankly, in the response.
Well, you know, Dan, we almost had to look up everything. Yeah. Any controlled substance, we were going to have to look it up. And we just couldn't do that. Primary care docs can't do that. And certainly not oncologists, hematologists couldn't do that either because they use a lot of those medications. It would consume so much of our time. So the way the bill originally was coming out, it was going to happen. So we got the can kicked down into September of 19. So that's coming up. And during this session, we're going to work very hard to limit that. Our House recommended we limit it to Schedule 2s, and so we may be able to do that. But the real fix that we want is the electronic fix so that we get information into the electronic record. It comes in automatically. If patients are getting opioids, it just comes into the record. We know that. They can do that. And we could also get emails. If you're still using a paper chart, it can come by email. But it should come from the physician drug piece that's out there that we're using now. It should just come into our electronic record. It should come to us by email. We shouldn't have to go proactively and look it up. We've got enough hassles. That's the administrative burden that's killing us all.
Yeah.
We've got to do everything we can to fight that.
We had a hearing yesterday in Austin, the Joint House-Senate Committee on Prescribing and Dispensing Controlled Substances, primarily looking at ways to improve the prescription drug monitoring program. Okay. Last session, as you know, I mean, it started off as you got to check it for everything, every controlled substance. It ended up not effective in 2017, but the pushed-off date for effectiveness was September 1, 2019. And it wasn't all controlled substances. It was 4 classes: opioids, barbiturates, benzodiazepines, and carossoprodol. Did I pronounce that correctly?
Close enough.
Soma. And yet, even with those 4 drug classes, the expectation of a manual system is extraordinarily burdensome on practitioners, both in terms of workflow interruption and time. And that is not a story for just physicians. That is a story told by dentists, by podiatrists, by everyone who prescribes, and it is a story told by pharmacists because they have the same responsibility to check before dispensing. And you're right. The majority part of the solution is going to come from the electronic integration of the prescription drug monitoring program with your EMR. But that's not going to be an even transition. Mm-hmm. But it is something that we should work forward to. But we also have to remember the folks, and the 15% of Texas physicians who tell us they do not use electronic medical records. Now, that number grows all the time, but there are still some who do not. And you know what? That's their right.
Absolutely.
We shouldn't force, and that's the other thing in terms of the integration piece, is making sure that the state appropriates the funds to do it and does not put the burden of funding these changes on top of the prescribers, physicians, and
well, as you know, we met with the Lieutenant Governor a couple of months ago, and he was very favorable, and he understood that we cannot move forward without some sort of payment plan, because it's kind of like what our group did with MIPS. You know, we had to modify our electronic record. It cost us about $10,000 to do MIPS, and then we got our payment the other day, and it was about $6,600. You know, I'm not real good at math, but I don't think that works right. So we've got to be sure that whatever we get in this electronic fix does not cost so much it's prohibitive to get it done.
So you're suggesting at that slow rate of loss, you can stay around for quite a while.
Yeah, it's a slow death, Dan. It's a slow death. That's right. That's exactly right.
Jason, let's ask the final polling question on the physician drug monitoring program, please.
Certainly, Dan. We would like to know if you in the listening audience are going to utilize the PMP Physician Monitoring Program. Press 1 on your telephone keypad for yes, press 2 for no, and press 3 if it's not applicable or you're unsure. So we're going to leave that open here for a moment while Dan gives us the results. And again, we'd like to thank everyone for their participation in our polling questions and for joining us this evening.
Great. Thank you, Jason. And I will tell you that very quickly, looking at your responses, it's about half of you are saying yes. I don't know if it's a trick question or not, because you know what? Not all doctors prescribe controlled substances.
That's correct.
And it's interesting. TMA polls, and bless you all for responding to the TMA polls, because we do poll you quite a bit. And in June, we asked physicians about electronic medical records. 85% of Texas physicians report that they use an EMR system. And of those that use EMR, 85% are electronically prescribing non-controlled substances. Of those that electronically prescribe, about half are already electronically prescribing controlled substances. And yet the very physicians, the surgeons generally, who electronically prescribe controlled substances also write paper prescriptions because of where they practice, perhaps in an ASC, Perhaps it's patient preference, a patient who simply wants the comfort of that prescription paper. So, we have to be flexible moving forward. I think that's part of our.
And Dan, before we leave opioids, I want to be sure everybody understands too that as we deal with this quote crisis that we're having, and certainly there have been way too many people die from overdoses, and we have to deal with that. But I want to be sure everybody understands that one of the greatest privileges we have as physicians is relieving pain, and we should do that. We need to manage opioids and use them appropriately, but we need to use them for comfort for our patients. It is the right thing to do, but we need to do that right, and we need to do it well. And so as we move forward, we want to figure out good things to help protect our patients that have issues with opioids, but we also want to be sure that we're relieving pain when there's pain issues.
And I think it's now 8 o'clock. Straight up, we've been on for an hour, and Dr. Curran, I want to thank you. I think it's a wonderful place to end the evening. Dr. Santos and the Harris County Medical Society, thank you for hosting us. It was a great pleasure to be here once again, and for all of you who have stayed on the line and participated in this, thank you for your participation and your membership in TMA. I'm going just a couple of announcements. If you have questions that you'd like to ask and have us answer later, please stay on the line. You'll be able to leave a voicemail, or you can email us at knowledge, KNOWLEDGE, at texmed.org, and we'll get an answer back to you as quickly as possible. Again, our thanks for joining us tonight, and just to close things out, I'll ask Jason to read our CME question.
Thank you so much, Dan. We would like to ask you in the audience if you're going to implement any of the strategies based on what you've learned in this call, and if so, which ones? Press 1 on your telephone keypad for attending TMA's first Tuesdays at the Capitol Lobby Days this session, starting in January here. Press 2 on your telephone keypad if you're going to sign up for TMA Legislative News Hotline email reports. Press 3 if you're going to respond to TMA Legislative Action Alerts. Press 4 if you're going to write, call, or speak with your legislator. And press 5 if you're going to implement more than one of the strategies previously mentioned. Dan, I'll let you know that overwhelmingly 54% of those who responded plan on implementing more than one of those strategies.
Right.
We thank everybody who's joined us this evening. This has been a live telephone town hall meeting with the Texas Medical Association. Just one quick note that if you had a question that we didn't get to, or if you even like to make a comment on this kind of forum at the end of this call, we are going to give you the opportunity to leave a voicemail. Just please do so by leaving your first and last name, as well as either a valid telephone number or a current email address. Just please spell that out and clearly state the domain name. Again, this has been a live telephone town hall meeting with the Texas Medical Association. We thank everybody for joining us. Have a fine evening.